Hello, my name is Lotus Aguilar. I'm a student physical therapist at University of Texas Medical Branch in Galveston, and this is my friend Ryan, who's going to be portraying as my subject for the day. I am going to be demonstrating a deep tendon reflex test on Ryan's biceps, which are innervated by the C5, C6 nerve roots. And so what we want to do when we're testing reflexes, you always want to, for instance, if we're going to test his biceps reflex on his left upper extremity, then you want to always follow the testing with the contralateral extremity with the same reflex, just so that you have two sides to compare. So we're going to begin the process here. So Ryan, I just want you to relax your arms onto you, just like so. And then I'm just going to put a little bit of pressure on the fold of your arm, and I'm going to use this hammer to elicit a reflex on that bicep, okay? Very good. And then we try the other side. Just relax for me, please. Okay. And so based on his responses there, they were pretty minimal. I mean, it's probably what I would consider normal, just because there was some twitching that I could feel, and there were some subtle movements that were existing through the reflex. So based on the scale, a 1 plus, a 2 plus, and a 3 plus are considered normal. So 1 plus would be traceable, 2 plus would be normal from what I exhibited here and what we experienced in his responses, and 3 plus would be where it's kind of a brisk, more of a brisk response to the reflex hammer. If it were a 0, there would be no reflex happening, and a 4 plus and a 5 plus would be unsustained and sustained clonus, which are all considered abnormal. So the next assessment I'm going to be doing is assessing Ryan's spasticity in his plantar flexors. So in this case, Ryan, I would ask you to remove your shoes for me. There we go, and we'll have you lie down on your back so you can be completely comfortable for me. Okay, so to assess spasticity, we're going to use the modified Ashworth scale, and it's basically going to measure resistance to stretch. So spasticity is basically what is velocity-dependent increased resistance to stretch. So when we do that, you want to be sure the patient's completely relaxed, because any additional tension in the muscles is going to increase that spasticity. So what we'll do here, the first thing we're going to do is check Ryan's passive range of motion in his ankle. So Ryan, if you can just completely relax your leg, I'm going to place my hands on your ankle and your foot. And then we're just going to see what his available passive range of motion is. So we're going to move his ankle into dorsiflexion. Just like so. Good. All right. And so now, because we've just applied so much input feedback into the muscle spindles, we want to just go ahead and let that relax before you actually perform the test for spasticity. So at this point, we would probably talk to the patient a little bit more, maybe do another assessment with Goni in the upper extremity, or maybe an MMT in the upper extremity. Let's say that that has passed, and we can come back to his lower leg at the ankle and do the test for spasticity. So Ryan, what we're going to do here is I'm just going to apply a quick stretch onto your ankle. So I just want you to relax for me. It shouldn't hurt. Very good. And then we'll do that one more time. Good. So what you are looking for here is you want to be sure that there's no resistance into the range of motion. There's no sudden catch in that range of motion, where it leads to another release where you feel more resistance into the remaining end of that range of motion. So that would indicate a degree of spasticity based on that scale. But at this point here, he would be exhibiting a 0, which means that he has normal muscle tone. So, and the one thing I did forget to mention was that when you're performing the quick, fast motion into the stretch into dorsiflexion, you want to be sure that it's just going about 55% of his available range of motion that we just recently assessed. Okay, so now we're going to do the same assessment, but we're going to just take the gastroc out of it and just assess the soleus muscle. So Ryan, I'm going to place this bolster under your knees. And relax here. Good, and just relax your legs onto the bolster for me. Very good. Okay, so we're going to do the same thing. I'm going to see Ryan's passive range of motion, what's available to him at his ankle. So Ryan, just relax for me. I'm going to just go ahead and move your ankle a little bit here. And you can see it's a little bit more motion than what he had available with the gastroc included. Very good. Okay, so once again, we provided a lot of input feedback into that muscle spindle. We want to let that quiet down for a little bit, so we move on to something else. We talk, we do another Goni or MMT on the upper extremity. We come back to it. Okay, Ryan, so I'm going to go ahead and put a little bit of a stretch in your ankle. So I want you to be relaxed as completely as possible for me. And then, very good. So once again, you just go about 55% of his available range of motion with the fast stretch, fast quick stretch. And here I didn't detect any kind of catch. I didn't detect any kind of resistance into that range of motion. And once again, I would consider that a 0 on the modified Ashworth scale, which would indicate normal muscle tone. So the other thing that I was going to discuss with this demonstration is basically the pathways for the technospinal tract. The technospinal tract is considered a medial upper motor neuron tract, and it functions basically to turn the head to look towards a auditory visual stimulus. So when describing the pathway, we have to know that it starts in the cell bodies of the upper motor neurons in the superior colliculus, which is in the midbrain. And the interesting thing about the superior colliculus is that's the structure that helps process information such as visual and auditory and somatic information. So with those cell bodies in the upper motor neuron at the superior colliculus in the midbrain, those axons are going to decussate immediately at the midbrain and descend down to the spinal cord, to the central region, the cervical region of the spinal cord, where it's going to synapse basically with the cell bodies of the lower motor neurons at the medial ventral horn. And then the lower motor neuron axons there are going to innervate the muscles of the neck to cause you to turn your head towards the visual and auditory stimulus. And that concludes our video for the day, and thank you so much for your time.